Hello TutorMed family, Dr. Obeng-Frimpong here again, and welcome back to the channel. You know we have simplified the interpretation of various lab investigations like the full blood count, the hepatitis B profile, CSF analysis, etc. And in today's video, we will discuss the interpretation of the arterial blood gases, the basics. If you are new here and you actually love what we do here on this channel, kindly remember to like this video and become part of the community by not only subscribing to the channel but also turn on your notification bell so you can be notified whenever we post new videos. You know someone this might benefit, probably writing an exam. Please be kind enough to share this video link to him or her. Alright friends, let's get started. Great friends. So what is the arterial blood gas test, and why do we want to request that for a patient? The arterial blood gas, also known as the ABG, is a test that measures the acid-base status of the body. And so if we suspect that a patient may have an acid-base disturbance, we order for an arterial blood gas test. It also measures the gas exchange status of a patient. How well oxygenated is our patient, and are the lungs expelling carbon dioxide as they should? And so if we suspect that our patients may have a form of respiratory failure, it will be in the right place to order for an arterial blood gas. There are other information the arterial blood gas test gives us which we won't dwell so much on, but we'll mention a few like the electrolytes and then the hemoglobin, etc. So basically, we want to order for an arterial blood gas test because we want to know the acid-base status of the body and we want to know the gas exchange status of the body. And so about the acid-base status, the ABG can tell us whether the patient has a normal acid-base status or there is acidosis or there is alkalosis. And regarding the gas exchange status, we can tell if the patient has a normal gas exchange status, type 1 respiratory failure, or type 2 respiratory failure by examining the ABG. Now before we look at the basic components of the ABG, let's see the points blood can be drawn from. And so as labeled A, B, and C, blood can be sampled from the point A, which is the brachial artery, from the point B, which is the radial artery, and the femoral artery, which is point C, as shown in this diagram. Other sites may include the dorsalis pedis artery and the axillary artery. Now, while some reference texts, particularly Oxford Handbook of Clinical Medicine, argue that the brachial artery is less preferred because it is an end artery, number one, and because the risk of median nerve injury is very high because of its proximity to the nerve, there are other medical authorities, including UpToDate, which maintains that there is no evidence that cites any site superior to the other. However, the radial artery is most often used because it is most accessible and more comfortable for the patient. Great. Now let's see the basic components of the ABG test. The first I would like to mention is the pH, which is the measure of the degree of acidity of the arterial blood. In other words, how much hydrogen ions are in the sample we took. The negative log of the hydrogen ion concentration gives you the pH. The normal pH of arterial blood is 7.35 to 7.45. This means any value less than 7.35 is acidic and any value higher than 7.45 is basic or alkaline. The next basic component we will look at is the partial pressure of carbon dioxide, symbolized as PaO2. Now, partial pressure of a gas in this sense can simply be seen as how much of that gas is dissolved in blood, And so how much of carbon dioxide is dissolved in blood? That is the partial pressure of carbon dioxide. Now, the normal value can be quoted in either millimeters of mercury or in kilopascals. In millimeters of mercury, the normal value is 35 to 45. And this is easy to remember when I know that this is the last 2 digits behind the decimal in the normal pH range, 7.35 to 7.45. So I just pick the 35 and the 45, and that is how I remember that the normal PCaO2 or PaCO2, in millimeters of mercury is 35 to 45. And in kilopascal, this range is 4.7 to 6.0 kilopascals. The third basic component is the PO2, the partial pressure of oxygen, which is the measure of the amount of dissolved oxygen in blood. Its normal range is 75 to 100 millimeters of mercury, although some books say it should be anything greater than 80. And in kilopascals, this is greater than 10.6 kilopascals, and so that is the normal range for the partial pressure of oxygen. Then we have the bicarbonate ions level, which should be between 24 to 28 millimoles per liter, although the range varies with different reference texts. So these are the 4 basic components, although there are other components. These are the 4 basic components we should focus on. Very good. So my friends, if you love what we are doing, kindly become part of this community by subscribing and hitting your notification bell. Now, what is our primary duty when interpreting the ABG? The first thing to do is to ask, is there any acid-base problem? In other words, is the patient's acid-base status normal, or is there acidosis or alkalosis? Next, if there is an acid-base problem, you want to know whether it is metabolic or respiratory in origin. After identifying the origin, you want to know if the problem is uncompensated or a compensated acid-base problem. And if it is compensated, you want to ask, is it a partial compensation or a full compensation? Then, is there any form of respiratory failure? And so these are the 4 steps we use to interpret the arterial blood gas, and they are the basic steps. There are other steps or other things you have to look out for, but for the basics, these are the 4 steps we use. Now the interpretation steps. Remember, the first thing to do is to ask whether there is an acid-base problem or not. And so to know whether there is an acid-base problem, first check the pH. Anytime you pick the ABG report, the first thing after confirming the identity of the patient is to check the pH. Remember that the normal arterial blood pH is 7.35 to 7.45. And so when you check the pH and it's within normal range, then most likely there are no acid-base problems. But if it is low, that is less than 7.35, then there is acidosis. And if it is high, then there is alkalosis. From here, the next thing is to check the origin of the acid-base problem. Is it respiratory or metabolic in origin? Now, I need to say here that acidosis and acidemia, although they are often used interchangeably, are 2 different subtle concepts. The process which causes the elevation of the hydrogen ions, that process is called acidosis. And then the elevation of the hydrogen ions in blood is acidemia. In other words, acidosis causes acidemia. So to give an example, diabetic ketoacidosis, DKA. DKA will be termed the acidotic process because it is a process which produces a lot of ketone bodies or keto acids, causing the H+ in the blood to increase, causing the acidemia. And so in this case, a DKA is the acidosis, and then what it causes is acidemia. So a pH less than 7.35 is better referred to as acidemia, while the process which led to the acidemia would be referred as acidosis, or will be referred to as acidosis. For example, in lactic acidosis, there is acidosis because the lactic acid produces or releases a lot of H+ into the blood, causing the H+ in the blood to become elevated. And so the process which led to the lactic acid production will be called lactic acidosis, but it will lead to acidemia. This concept is also true for alkalemia and alkalosis. Now, to understand the origin of the acid-base problem, we need to understand the two main organ systems involved in acid-base balance. We have other buffer systems, but we are interested in the two main organ systems. We have the respiratory system and then the renal system. Now, day in, day out, the body is subjected to conditions which offsets the acid-base environment. But the respiratory and renal systems, together with other buffering systems, work efficiently to keep the pH within the normal range, which is 7.35 to 7.45. Note that this is the normal range for an arterial blood. And so how do these systems work? How does the respiratory system work to control acid-base balance? It does so by either retaining carbon dioxide or expelling carbon dioxide. It means that carbon dioxide is the weapon the respiratory system uses to regulate acid-base balance in the body. Now, carbon dioxide is an acidic gas. And so if the respiratory system senses that the body is becoming too acidic, the respiratory system will try to expel more carbon dioxide. And so you will see the patient breathe fast, and that is hyperventilation. And if there is alkalosis or alkalemia, in that there is less hydrogen ions in the blood, what do you think the respiratory system will do? Do you think it will expel carbon dioxide or it will retain carbon dioxide? No, it will retain carbon dioxide because it wishes to make or create a balance for the acid-base environment. So the respiratory system uses carbon dioxide, that is the baseline, and so the partial pressure of carbon dioxide speaks for the respiratory system. What does the renal system use? The answer is bicarbonate ions, which is a base. So whenever there is acidemia, which is a lot of hydrogen ions in the blood, the kidneys will try to retain more bicarbonate ions to balance the acidity. And if there is alkalemia, the kidneys will excrete more bicarbonate ions. Now that you understand this principle, we are good to go. And so let's see how to determine the origin of the acid-base problem. And so now, how do you tell the origin of an abnormal pH? You now know the weapons each of the two systems use to regulate acid-base status. And so let's take an example. We checked the pH and the pH was low, that is less than 7.35. Straight away we know that there is acidemia. It means that there is something which is causing elevation of hydrogen ions. That is why there is acidemia. And so you check the partial pressure of carbon dioxide, which is the respiratory component, and then the bicarbonate ion level, which is the metabolic component. You know that these are the weapons the respiratory and renal systems use respectively. And ask yourself, which of the two rationally explains it? Now, remember that carbon dioxide is an acidic gas, and so it can only explain a low pH, that is an acidic pH, when its level is high. And so for this patient who has a low pH, when you check and then the carbon dioxide level is high, then it's likely that the respiratory component is the one explaining why there is acidosis or acidemia. And so this acidemia is of respiratory origin. Now, bicarbonate ions are basic, and so they can only and rationally explain a low pH when its level is low. If, for example, its level is high in the light or, in a picture of acidemia, then it does not rationally explain a low pH. And so the point here is that if there is acidemia, a high PCO2 would suggest that the problem is a respiratory problem. And then a low bicarbonate ion level would explain that the problem is a metabolic problem, and so respiratory acidosis and then metabolic acidosis, depending on which of the two components rationally explains the pH we've seen. And so based on this principle, we've been able to determine the origin of the acid-base problem. After you've identified the pH level, check which of the two components rationally explains it, and that will be the origin of the acid-base problem. And so another example, what if the pH is high, that is a pH more than 7.45? Straight away in our heads we know there is alkalemia. It means that there is a process which has caused decreased amount of H pluses in the body or increased amount of bicarbonate ions in the body. That is why the pH is very high. Again, after doing this, what do? You check which of the two systems rationally explains the pH you are seeing. If it is a low partial pressure of oxygen, then it makes sense that it is a respiratory alkalosis. And if it's a high bicarbonate ions, you know that then this rationally explains the pH we are seeing. And so because the bicarbonate ions rationally explained what we are seeing, then it is a metabolic alkalosis. Good. So now you can easily identify a metabolic acidosis and an alkalosis, and then a respiratory acidosis and then an alkalosis. Then, as you know, the next step is to ask yourself, is the acid-base problem you have identified compensated or uncompensated? And if it is compensated, is it a full or a partial compensation? Now, it is important to know that the two systems, the renal system and the respiratory system, compensate each other. What I mean to say is that if the problem is a respiratory acid-base problem, then you would expect the renal system to compensate. And the vice versa, if the problem is a metabolic problem, then you would expect the respiratory system to compensate. And so note that if there is respiratory alkalosis, then the renal system should compensate. If there is metabolic alkalosis, then the respiratory system should compensate. And so what I want to say here is that these two systems compensate each other. And so to throw more light on this, if the primary cause of the acid-base problem is respiratory, then remember I said the metabolic component would compensate. And the point I want to make here is that the metabolic component, the compensation or the metabolic compensation happens relatively slowly. And so, for example, if you have respiratory acidosis, because there is more acid in the body, what do you think the kidney will do about the bicarbonate ions? The kidneys will try to compensate by retaining more bicarbonate ions. And so this will manifest as a raised bicarbonate ion. And if there is respiratory alkalosis, because there is so much alkalosis or alkalemia, it means that the hydrogen ion level is down, and so the kidneys will try to compensate by excreting more bicarbonate ions, and so that is the rationale. And so you will note that the kidneys compensate when there is a primary respiratory problem. The key point to note here is that the metabolic compensation happens relatively slowly as compared to the respiratory compensation for a metabolic problem, which we'll see later on. Now, whenever the primary cause is metabolic, as a principle, the respiratory system compensates. And here I want to mention or repeat the point that the compensation by the respiratory system happens relatively faster. Remember, we said the metabolic compensation happens relatively slower. And so if there is metabolic acidosis, how will the respiratory system compensate? Because there is too much acid, it would like to excrete carbon dioxide rapidly, and that is what we'll call hyperventilation. And that explains why we see hyperventilation in a patient with diabetic ketoacidosis. Good. And if there is metabolic alkalosis, because there is so much base, the respiratory system would like to retain the acidic gas carbon dioxide, and so that will manifest as an increased PCO2, right? Very good. And so how do you tell that the problem is uncompensated? We are on step 3. Let's take an example. We have metabolic acidosis. You know that the first thing you have to do is to check the pH, which will be low, that is less than 7.35. And then what makes it metabolic is that there is a low bicarbonate ion, and so that is metabolic acidosis. Now, in compensation, remember that we said that whenever there is a metabolic problem, the respiratory system tries to compensate. And so the respiratory system is supposed to compensate by excreting more carbon dioxide, because the carbon dioxide is acidic, and so if more is excreted, it will limit or it will reduce the acid status of the body. And so this should manifest as a decreased PCO2. So once you see a decreased PCO2 in the metabolic acidosis, then it means that the respiratory system has started compensating. But if the PCO2 has not changed, it is normal or is still elevated, it is normal, that is the word I should use, it is normal, then it means that the respiratory system has not yet started compensating. And so the key notes here is that whenever there is an acid-base problem and if you identify the origin, check the other component, whether it is also changing. If it is changing appropriately, then most likely there is a level of compensation. And so let's see how to identify a fully compensated or a partially compensated acid-base problem. Full compensation or partial compensation. Please follow closely. We will look at examples later. The first thing to do is to check for evidence of compensation and see if the pH is anywhere close to normal. So these are the two principles. Check for evidence of compensation and see if the pH is anywhere close to normal. And so for partial compensation, there is evidence of compensation, but the pH is nowhere close to normal. It means that if there is metabolic acidosis, for example, you'd expect that the respiratory system would compensate for it. And so the respiratory system will start compensating, but still, the pH will still be in the low range. That is a partial compensation. Now, in full compensation, there is evidence of compensation and the pH is close to the normal. Now, why am I not saying that the pH is fully corrected? Because according to Guyton and Hall physiology, the pH is almost never corrected fully unless the process which is causing the acid-base problem is removed. Very good. And so let's look at examples to consolidate our understanding. This is the arterial blood gas of a man, 65 years old, Mr. AK. What is the first thing we do? We look at the pH. and that is his pH 7.25, and it is less than 7.35, and so we think that he has acidosis or acidemia. The next thing is to determine the origin of the acidosis, and so what we do, we look at the PaCO2, that's the partial pressure of carbon dioxide, and then the bicarbonate ion level, and then ask which of them rationally explains the pH we are seeing. And so we go to the PaCO2. You know that this is an acidic pH, and so for the respiratory component to rationally explain the acidic pH, it has to be high. As in, when it is high, it means that it is being more retained. That is why the pH is like that. But when you look at the PaCO2 here, it is normal. It means that it cannot rationally, or it does not rationally explain the pH you are seeing. And so let's go to the bicarbonates and see. When you check the bicarbonate, you realize that the bicarbonate is low. Bicarbonate is a base, and so if the base is low in the blood, it means that the blood's acidity will go high. What it means is that the pH we are seeing is being explained by a metabolic problem, and so this will be a metabolic acidosis. Then the next thing to look out for is to ask, is the respiratory system compensating? We know that once there is metabolic acidosis, the respiratory system should compensate by expelling more carbon dioxide, and then the expulsion of the more carbon dioxide should manifest as a decreased PaCO2. But you check the PaCO2 here, it is still within normal range. What it means is that the respiratory system has not yet started compensating for the acid-base problem, and so in summation, this will be an uncompensated metabolic acidosis. Very good. And so let's take an example of the same man. 65-year-old Mr. AK, his arterial blood gas. After confirming the identity of the patient, what we do, we check the pH. And so his pH is 7.29, and that is less than 7.35. And so that is acidosis or acidemia in our heads. Now we need to find out if the acidosis is from a respiratory origin or a metabolic origin. And so we go to the PaCO2. This is an acidic pH, and so for a respiratory component to explain what we are seeing, it means that the respiratory system is not able to expel so much carbon dioxide. In other words, carbon dioxide is retained. That is why there is a low pH. Okay, and so if this problem were a respiratory problem, the carbon dioxide should have gone up to rationally explain the pH we are seeing. But it isn't so. So it means that this problem is not likely to be respiratory in origin. We go to the bicarbonate ion, and then we see that the bicarbonate ion is 20, lower than the lower limit. So it is low. Once the base is low, it means that it explains the pH we are seeing. So this makes this kind of acid-base balance or an acid-base problem metabolic acidosis. Now we move on to check whether it is compensated or not, and if it is compensated, is it partially compensated or fully compensated? Now you watch the PaCO2 level, you'll see that the respiratory or the carbon dioxide level has gone down. What that means is that the respiratory system has started expelling so much carbon dioxide out that carbon dioxide now is low. Why is it expelling so much carbon dioxide? Because it wants to compensate for the acidic pH. However, despite what the respiratory system is doing, the pH is still far from normal. And so because it is not close to normal but far from normal, this will be a partial compensation. And so in total, we have, or in summation, we have a partially compensated metabolic acidosis as the answer. Let's take a look at another example. Same patient, Mr. AK, 65 years old. We've confirmed the identity. We check the pH. The pH is 7.33. Whatever be the case, it is still less than 7.35, although it is relatively closer to normal. But because it's less than 7.35, we say that there is mild acidemia. So there is acidosis. Okay. Then we ask ourselves, which component explains the acidosis we are seeing? So you check, obviously here, It is a bicarbonate component. It explains the acidosis we are seeing because it is low. And so this is a metabolic acidosis. Then we go and check, is there compensation? Of course there is compensation because the partial pressure of carbon dioxide is low. What it means is that it is low in the blood because the respiratory system is expelling it more and more and more to compensate. Now, is this fully compensated or partially compensated? We will say it is fully compensated because what this means is that the respiratory system has compensated so much so that the pH is now nearing normal. Okay, and so this is a fully compensated metabolic acidosis. Remember, I cited Guyton and Hall explaining that until the primary process, which is causing the acid-base problem is removed, the compensating system may not be able to compensate it fully, we may not be able to bring the pH to its normal state because the process which is causing the acidosis is still there. And so the best the compensating system can do is to bring the pH close to normal. And so, like I mentioned, the last step is to determine whether there is respiratory failure or not. Remember, we have two types of respiratory failure. We have type 1 respiratory failure and then type 2 respiratory failure. And so how do you identify type 1 respiratory failure? In type 1 respiratory failure, there will be hypoxia, but a normal level of carbon dioxide. And so there will be a decreased partial pressure of oxygen, that is hypoxia, and then a normal partial pressure of carbon dioxide. And in type 2, there will be a decreased partial pressure of oxygen, so hypoxia, and then there will be an increased partial pressure of carbon dioxide, that is hypercapnia. And so the way I like to think about this is that in type 1, only one gas has a problem, and the gas is the gas is oxygen. So only one gas is deranged. And in type 2, all the two gases are deranged. There will be a decreased partial pressure of oxygen and an increased partial pressure of carbon dioxide. So two gases are deranged. Type 1 gas, just one gas. Type 2 gases, all the two gases are problematic. And so kindly take note of that. And so, ladies and gentlemen of the TutorMed community, what is our take-home message from this presentation? In interpreting arterial blood gas, especially during an OSCE or during an exam, the first thing your eye should be looking for is the pH. So that will help you answer the question whether or not there is any acid-base problem. Then the next thing is to find its origin. So where is it from? Is it metabolic or respiratory? Then the third thing is to find out if there is a compensation for the acid-base problem. Is there compensation or not? Then fourth, if there is compensation, is there a partial compensation or a full compensation? We've gone through that. And then the last but not the least, in the basic interpretation of the ABG, is to find out if there is a form of respiratory failure by looking at the partial pressure of oxygen and then the partial pressure of carbon dioxide. And so thank you for making time for this presentation. See you in our next presentation. And until then, bye.